nearly 200 million people by the end of the century under RCP 6.0 exposed to that level of heat for 3 consecutive days. So that will be a major challenge to habitability, particularly in those areas that don't have ready access to air conditioning. We're also seeing the emergence of diseases that may be related to climate change. One of them is chronic kidney disease of unknown origin, which is a disease which has been emerging in a number of parts of the world, particularly in Central America, where it was really first described. It's unexplained by conventional risk factors such as high blood pressure and diabetes, and it predominantly affects adult male agricultural workers, particularly sugarcane cutters, to some extent construction workers, and to a lesser extent farm workers. And that's probably because they're on piecework rates, so they get paid according to how much work they do, and they often have to work in extremely high thermal stress conditions. This kidney disease is devastating. It causes a rapid decline in kidney disease, in kidney function. Many of these countries don't have transplant programs, and it causes the early death of an increasing number of, particularly of relatively young men. And this slide just shows you the kind of exposures that they're subject to, around 30 degrees in many cases in Costa Rica. 30 in the wet bulb globe temperature metric. So it's not at the very highest level, but fairly high level exposures to thermal stress. And the key hypothesis for the increase in this condition, which is now being experienced in southern India and Sri Lanka and other parts of the world, is probably due to this exposure to extreme heat stress with inadequate hydration. There are other hypotheses too, like pesticide exposure and so on. But I think the most likely one is some relationship with heat stress exposure. And a lot of work going on to try and understand the cause of that condition and to see whether it can be prevented by early intervention, particularly related to hydration, shading, and so on. Moving on to some of the indirect effects, we've heard quite a lot of this conference about the effects of climate change on staple crops, and that's obviously very important in terms of food security. But I want to draw our attention to another category of crops that are very important for human health, and that's fruit and vegetables. Fruit and vegetables are a very important risk factor for non-communicable diseases. So inadequate consumption of fruit and vegetables is a major risk factor for heart disease, stroke, some types of cancer. And you can see from this slide from the Global Burden of Disease that it's a very important dietary risk factor. Low fruit consumption, particularly in low-income countries, responsible for perhaps 9% of total deaths. Low vegetable consumption, another 3 or 4%. So between them, a very major risk factor for non-communicable diseases. And it's likely that climate change will put additional downward pressure on fruit and vegetable consumption, and some emerging data that we have from a systematic review that's being done at the moment, led by my colleague Pauline Shielbeek, quite a major undertaking involving screening 60,000 abstracts of papers, but then distilling that down to a relatively small number of appropriate papers looking at field studies and also greenhouse studies. And what we've done is to look not just at temperature, but also a range of other relevant environmental variables like CO2, water availability, and ozone. And this slide just summarizes some of the emerging results on fruit. You can see that CO2 does increase yield, or quite a lot of uncertainty. Reduced water availability, increased temperature, and increased ozone all decrease yield. And when you put them together, the overall effects are likely to be a reduction. So that suggests that under climate change, fruit production will fall, and particularly in low-income countries where intake is already inadequate, that will exacerbate the problem. If we look at vegetables, which are the other key determinant of NCDs, as I've mentioned, you see a slightly more complex effect. We've broken it down here, and in the temperature section, you can see we've looked separately at those where the baseline is less than 20 degrees, where you do see an increase in yield, and those where the baseline is greater than 20 degrees, where you see a decrease. So overall a decrease, but it depends on what the baseline temperature is, with considerable uncertainty. CO2 fertilization, you do get an increase in yield, but you also get a decrease in nutritional quality. So when you look at the important minerals like zinc and iron, which are very important for human health, you can see on this slide that there's a negative effect of CO2 on the content of zinc and iron, and that will have big implications for micronutrient deficiency, which are a very major health issue in a whole range of countries. So overall then, negative effect on fruit and vegetables, with some counterbalancing of CO2, but that comes at a cost, which is decreased micronutrient levels. So in all probability then, this will add to the challenge of reaching the nutritional targets for fruit and vegetables in years to come. But in the second part of my very brief talk, I want to try and focus on one or two solutions. And I think it's very important for a conference like this to focus on solutions. As we heard yesterday, policymakers aren't generally interested in problems as such. What they want is potential solutions to them. So what we've been doing in recent years is to work on policies which can help to mitigate climate change, but also bring with them large co-benefits to health. And the first group of policies are those that can be implemented in cities. Cities are crucial because they're the engines of economic growth and social change, 85% of GDP and about 3/4 of greenhouse gas emissions. And this slide just illustrates one challenge of cities, and it compares two cities, Atlanta and Barcelona. And what you can see is that they host the same population, about 5 million people, but they have very different urban areas, about 10 times as much in the case of Atlanta. And that means that their transport carbon emissions are about 6 or 7-fold greater in Atlanta than Barcelona, because of the fact that this is a very sprawling urban area and you can't use, well, public transport is inadequate and it's very difficult to walk and cycle. And this in turn has big implications for human health. So transport, air pollution, water availability, the urban heat island, air pollution, these are all challenges of the growing urban environments which will need to be tackled in order to mitigate climate change but also improve human health. We and others have done a lot of work on modelling the likely effects of sustainable transport pathways in cities, and we've shown that overall there are potentially large benefits to human health if you get the policies right, and that's partly through reduced air pollution but also through increased physical activity. And sedentary lifestyles are a big killer around the world. They kill about 3 million people through increasing the risk of heart disease, stroke, and a range of other conditions. So this slide just shows you how many cities are responding to the challenges of sustainable development by scaling up sustainable mobility policies, whether they be car-free zones, bus rapid transit systems, car sharing, bike sharing, low emission zones, and so on. So we're seeing a lot more activity at the city level than we are at the national level in terms of climate change mitigation and policies to create sustainable, healthy communities. That's not to minimize the challenges ahead, but to say that we already have 7,000 cities signed up, for example, to climate change mitigation strategies. So optimizing transport and energy policies in urban environments is key for improving health and reducing carbon emissions. There's also increasing interest in green space exposure in cities, and this slide just summarizes some of the mental health benefits that come from increased exposure to green space. Green space also has other health benefits in terms of reduced cardiovascular disease and also reduction of the urban heat island effect. There are many benefits from reducing air pollution through low carbon policies, which are summarized in this slide, the red areas where you get big health benefits. And also, if you value these benefits in terms of marginal cost benefit analysis, you can also see major economic benefits, particularly in East Asia, but overall, globally, the health economic benefits outweigh the costs of introducing low-carbon policies. There's emerging growing evidence around forest conservation. We know that forest burning is a major contributor to greenhouse gas emissions and also to loss of biodiversity, and a growing body of evidence suggests that forest conservation can decrease transmission of malaria, reduce air pollution, and produce clean water. Also, environmentally sustainable dietary patterns. This again summarizes a systematic review that we've recently done showing reductions in greenhouse gas emissions with healthy diets, not as much as vegetarian diets, but still worthwhile. And finally, of course, health. We're going to, I guess, talk about Sustainable Development Goals tomorrow, but health is really a cross-cutting issue. Many people focus on SDG 3, but really health is a cross-cutting issue across the SDGs. SDG 1 on poverty, 2 on agriculture, 7 on clean energy, 11 on cities, and so on. They're all inextricably bound up with human health. So human health, I think, is the major cross-cutting issues which is exemplified in many of these SDGs. So I'll stop there. Sorry if I've overrun by a couple of minutes, but hopefully there's at least 1 or 2 minutes for questions. Thank you very much.
Thank you, Andy. Yes, so we have time for 1 question, or maybe 2. Let's see how long they are. So, questions. Yes.
Rainer Sauerborn. Thank you, Andy, for a wonderful presentation. I have a question regarding the CO2 effect. It's the famous fertilizer effect, and you showed arrows that were in the negative and that were in the positive range. Is it not also geographically? In the north, you get a lot of fertilizer effect, and in the global south, you don't. So we have a distributional problem on top of all the other distributional problems.
Yeah, there may be differences geographically. That's something we're looking at the moment. This is a systematic review that's still in progress, so we'll have more data on that. The challenge is that although you start out with a massive number of papers, we screened 60,000 abstracts, as I say, when you get down to the good quality research, it's really quite small. And the other striking thing that we found was that quite a lot of the studies don't even give you confidence intervals. So it's quite difficult to do a formal meta-analysis. You end up with giving kind of headline figures. And one of the issues that's really coming out of our systematic review is the need for better quality standards for these kind of studies, more consistent methodologies, more consistent reporting standards, so that we can really get much more fine-grained evidence about different countries, different parts of the world, and particularly about combinations. One of the big gaps in evidence is studies that have looked at a combination of CO2, temperature, water, ozone together, because that's going to be the reality of things. And so many of these experiments are quite artificial and maybe don't give us a real idea of what's going to happen on the ground. So we're going to make a plea for more rigorous research, but also research that reflects what's likely to happen over coming decades.
Okay, thank you. Because we don't want to eat too much into the coffee break, we will move on to the next speaker. The next speaker is Professor Christian Witt. He's a professor of pneumology in internal medicine at Charité, one of the biggest university hospitals in Europe, here in Berlin. And we look forward to hear some background, some study from clinical climate impact research.
Thanks. My topic is clinical climate impact research. That means the work on the patient, and I'm focused on the lung due to my profession. I'm university professor for pneumology in the Charité, and I want to close the gap between the clinicians and the data from statistics. And let's go on. At first, where we are, you look at the pink. You all can the IPCC list, and on the pink area, you can see where we are. We have cardiopulmonary or cardiorespiratory impact following to the climate change. And if you look at the importance of that, on the 4th position it is here, following malaria, following diarrhea, following malnutrition, that are not the topics in our area. And looking at the lung, we can point out that the main interest is on lung obstructive disease. That means chronic pulmonary disease, COPD, its abbreviation, and asthma as well. And on the other side, allergic diastasis. And let's point to the left side. Lung cancer is one topic. We have more and more patients without any smoking history, and therefore we ask also female patients are, the part is growing, and so we ask, what about the relationship? And as you can see, we have a relationship probably between climate change, air quality, lung cancer, as well as inflammatory disease as a precancerous situation or condition for that. And what is happening in the lung if heat meets the lung? I can say here hyperventilation, fluid loss, perfusion is reduced. And at the end of the day, the imbalance of defense mechanism of the lung and the bronchi, and therefore we have more infections and more deterioration of pre-existing cardiopulmonary diseases. And the kick-off paper 10 years ago was from Michalozzi from Rome to look in different European cities about the emergency visits of patients. They come during heat waves in heat periods. And the interesting result is that we have more patients with respiratory diseases than with cardiovascular diseases. It's not a competition, but it's a little bit surprising. In front of, we thought all the day at the time before, the cardiovascular diseases were more prominent about the surrounding factors or environmental factors than lung diseases. And therefore, it's one reason to say maybe the lung, the portal organ of internal organs for the climate change. And confirmed were these by mortality investigations in 15 European cities. As you can see, the respiratory mortality in the Mediterranean cities, and in comparison to northern continental, also this area, it's higher than the cardiovascular mortality. Now we investigated by ourselves about something on 100 million patients in papers, a meta-analysis of the literature. We have in mortality increase, in daily excess mortality increase about 14%, and look at the morbidity until 9%. There's something happen in the heat, in heat waves and heat environment for the patients. And we are focused on our clinical climate change impact research. We are looking not for healthy patients. You have the relation between climate change and health. We are looking more for patients, for illness, for disease. That is our research connection called UCAS, Urban Climate and Heat Stress in Berlin, and a lot of institutions are connected in this research platform, the PIC as well as Charité, and well granted. And why Berlin? Berlin is a model city for that. We have not significant influenced by oceans or mountains, and it's not air conditioned like other countries, and so we have good possibilities to perform here the research. And our goals were quantification of heat stress to your information. That means for me identification of vulnerable groups. That was the efficacy and implementation of adaptation strategies. That means cooling means for the medicine means to develop cooling systems. And what about the situation in Berlin? That is from Mrs. Kleinschmidt and research about heat islands in Berlin. You see the red points here. This is increasing due to climate change or warming. And you see the number of deaths in Berlin in the hot summers. 2006, there was championship of the football, and 2010, more additional deaths compared with other years. And that was also the kick-off point in the clinical medicine. For me, for example, to say 2006, all patients were stressed due to heat in the patient's room, the hospital. We have more deaths, patients on the waiting list for transplantation, and therefore we decided then to make something about the environment, not only the medical treatment. That was our model. We have taken COPD patients, that means chronic obstructive pulmonary disease with different stages, and we looked at morbidity, about the mechanism of vulnerability, mortality. But this disease is a little bit seasonal distributed. That means we have less exacerbation in summertime, more in the cold period. And we thought, therefore, are there other patients? Are there other phenotypes of disease? Fat, for example, or slim? Or what about other parameters to define the phenotype? And in the tropes, it's an anecdotal information for you. It's not seasonal different, it's equal over the year. And this is our research approach: heat stressed patients in an outpatient manner to assess vulnerability, to assess heat stress. And the second part is what we are doing with them in the hospital. We investigated into a cooling system and installed in patient's room this cooling system. And the first result was, before that, we investigated the outpatient area, and we found in 29 degrees, more than this, we have more hospital admissions in the Berlin area than in colder days. And on the other side, you can see the efficacy of the lag days. And this is a good information for the recreation of the medical system in Berlin. The second investigation was in different urban hospitals. See at the blue points here, look at patients, a lot and a great number of that, and to look at the phenotype. And one we found that the phenotype is a little bit depending on the stage of the disease, not the advanced stage, but the lower stage, stage 3, that's a gold stadium, or stage 2, were more affected by heat than others. So this is also concerning vulnerability, a young, in a publication, and as you can see, we have COPD as vulnerable group compared to normals. There's no difference in the gender, but the difference in the age, and not the oldest are so vulnerable, and therefore we have here new informations. And the other point is who adapted is the population, also the ill population in our countries. 90 degrees Fahrenheit is more adapted than 60, Alaska, versus Texas, for example. In Berlin, we are here, and so I think we have to do work on that field in addition to our activities. The last point is what can we do with patients in the hospital, question adaptation strategies. That's the first advice, that climatization reduce the mortality of patients with COPD, and therefore we installed these climatization, a novel technology with capillars, with cooling fluid, so that we have a radiation cooling system, by convection of air. And this is a finished work of that, and you can see the capillary system in the windows here, the patient. And these are our data in the control room. It was a randomized control trial. The control room until 30 degrees and 23 degrees, was in the patient's room with climatization. And our results for first, we can reduce our length of stay, we can increase the activity of our patient. Therefore, because we have earlier mobilization through climatization, we can discharge them earlier, 1.5 days earlier than without climatization. And an interesting side effect is here on the last point, slide. As you can see here, there's a difference between summer and winter, and we think to increase, for example, the air in the patient's room in the cold period may be led to the same effect like in the hot areas. So my last slides, that was the past in the pneumology, tuberculosis, 150 years. In my childhood, it looked so with the X-ray truck in the villages. And then we have the area of lung cancer. But the new area is the climate change, to include and take this into the account of our thinking. And I was very glad to see that the US colleagues were agreed and say, okay, we take it into account, 87% take the climate change as reality and to deal with that. And on the other side, it is more interesting, the patients, they have make an election, and the patient speaker is Caroline here, and both are working together to deal with the things. This is a very political slide to say what do we need in capacities in the future. More, if we have a bad climate scenario, and you know it better than I, we need until more 600 patients more in the New York area if we have not a decelerated process of climate change. now we are working together with the peak, and it's a very big deal, with health damage function to define that, what can he do with us here for patients, that is generate information for insurance, health insurance, and to say more about this amount. Last not least, Darwin is one of the greatest, I think, and he will advise us a little bit to what to do, adaptation, mitigation, high adaptation, 80% on the right side. And this is our hospital, and this is our station for climate or weather measurement, and thanks for all who contributed to that work. Thanks for attention.
We have time for 2 questions. I would have a question then. If I understood it right, you found that both in summer and in winter, you had a positive effect of your newly installed cooling system or air-through system. You have any hypothesis on the mechanisms that are in play?
We have British data from COPD patients. They will more exacerbate if this is cold and not sufficiently heated in the flats. And this was the indicator to say what is in winter with them, because it's so, and therefore one approach now is to take the same temperature, 23 degrees Celsius, for the winter in that rooms, and to enforce and to accelerate the reconvalescence period of the patients. That was the background. And if you say we haven't any relation and we haven't any about heat, we have a lot information, not enough, but a lot, but not about the winter. And the winter is sometimes more different, the climate change, than in summer. I have heard 3 degrees Celsius more, the winter is warmer than the summertime. And therefore we have to, I think, also to focus on that effect of climate change. And is it here? I have it here. You can look here down on this red area here about the difference between summer and winter. That is one approach to focus also on the winter if you have temperature investigations.
Okay, so thank you. Then we move on to the next speaker. The next speaker is Antonio Gasparini. He is an associate professor also at the London School, and we look forward to hear his talk.
So, good morning again. So my name is Antonio Gasparini. I want to thank the organizers anyway for this session and for inviting me. So the idea for today is that I'm giving you a different perspective, which is a perspective of an epidemiologist on studying climate change, and in particular I will focus on a specific impact, which is the direct impact of temperature on all-cause mortality. And I will discuss and present the results of just one single study. I will try to be brief and to focus more on the results later. So I will start with something that everybody knows about, which is an infamous heat wave happening here in Europe. And well, you had many figures in the newspapers about the impact, but I think these slide tells you everything about what happened in the specific summer in Paris at this time, meaning we have a kind of impact on health which is registered if you look at this kind of time series plots only with earthquakes or tsunami or events like this. So we are dealing with this kind of health impacts, and of course we all know that these should be projected in a future in which you have climate change and big changes in the temperature exposures of different people. So we are very much interested in understanding how to model these effects and how to project these effects in the future. However, this is not really an easy task. This is a very old, at the moment, paper by Corriero showing different exposure response curves for temperature in different cities. And from here you realize that the impact is not just related to heat, but also to cold, that you have different shapes in different cities because of the heterogeneity of the effect. And something is not shown here. It's also that you have adaptation in time to the exposure to outdoor temperature. So everything changes and everything is very difficult to model. This is one of the reasons we try to develop a collaboration, which is called Multi-City, Multi-Country Research Network, involving many different researchers from different parts of the world. The advantages of having this collaboration is dual. The first one, and I'll start with the second one, is that we were able to develop a more flexible modeling framework to address all the methodological issues in studying temperature and the effects on climate and temperature. But the second one is the first one in this case, is that we were able for once to give a global perspective to the problem. You know, maybe people working on climate or maybe also in economics, you are used to deal with data from all around the world and to give this global estimates of, global pictures. In epidemiology is much rarer because usually everybody is doing his own study and presenting his analysis for Barcelona or London, whatever. So this was the main reason for developing this network. I want to acknowledge, the participation of a long list of people who are currently collaborating, and one of the main benefits of having this collaboration is that we were able to collect this massive data set, collecting, time series data for 520 cities in 28 countries at the moment, including a very high number of deaths. And these data set spans many countries around the world, and we are covering many different areas, in particular from tropical regions in developing countries to temperate regions to very cold regions. Something I want to stress here immediately, of course, we have this kind of global perspective, but we don't have global estimates because entire regions of the world, for example, Africa or the Middle East, are not covered. So I don't want to waste time explaining the modeling framework, just saying that we have worked on this for years now in order to develop models which were able to capture all these complexities in the relationship with temperature. And by applying this modeling framework, we were able to analyze all these big data set and to gather information in terms of exposure response estimates primarily from many different cities. Now, we published quite a number of papers now, but I want to focus on this one in particular to introduce what I'm talking about later. Basically, in this paper, we analyzed all this data and we derived some measures for measuring so-called excess mortality, meaning, in this case, the percentage of additional deaths that you have due to different temperature ranges. And in particular, in this graph, we are showing that most of the mortality effects due to non-optimal temperature is actually because of what we called mild cold, because it actually, the main reason is that it includes a larger number of days throughout the year. And this is quite common across all countries, of course, with some differences. Now, one of the problems in presenting this a couple of years ago was about misinterpretations about these data. These data refer to what we are measuring now, not what we will measure in the future. I usually try to avoid putting, slides about specific news in my presentations, but I couldn't help myself this time because, this guy is the former Prime Minister of, Australia. He gave a speech a couple of days ago in London, and it apparently he cited the paper I've just shown, and I'm flattered, but also a little bit disappointed because you know, he gave this speech, I think, 30 minutes walk from my office. So he could come, knock on the door, and ask me what I thought about this, because it is exactly what we are publishing now, and we have a new paper about projecting this impact in the future. So for this paper, we have used the dataset from EasyMIP, and this was a very good source of data for us because it covered basically the whole world. So we could link all these cities to the specific temperature projections and to run these complex models that maybe we will talk about later in the afternoon or maybe later in one of the workshops. So I don't want to spend time about describing the method. Well, the idea is that we can link all the cities, and all the cities, of course, they have different common patterns across, in this case, RCPs, meaning different scenarios of global warming. But, of course, each of them has a different trajectory in terms of increase in temperature and temperature distribution in the future. So we were able to link all of these, and now I'm presenting the first results, which is presented in a paper which has been just accepted yesterday. So this graph shows the trend in excess mortality due to cold in blue and heat in red in different regions of the world, but also for different RCPs, from RCP 2.6 to RCP 8.5. Now, of course, there's a common pattern. Cold-related deaths always decreases, heat-related deaths always increases. And, you know, this change, of course, is more extreme in the more extreme, of course, scenarios, just like RCP 8.5. But, of course, there are big differences across regions, and in particular, in some regions, just like North America or north of Europe, temperate regions, the change is more moderate, while in some areas, in particular Southeast Asia, is the middle right, panel, and for example, other regions, just like South America and South of Europe, there's a dramatic change, but especially a dramatic projected increase in heat-related deaths. And this shows the change if comparing the current decade with the last decade of the century in terms of heat, showing for each city what is the range of increase in heat-related mortality. And this map tells you that we will measure big changes, but these changes are not the same in all the areas of the planet. In particular, there are some areas, just like south of Europe, but in particular Southeast Asia and some places in South America, when the increase in heat-related deaths, as shown in the other graph, is dramatic. Now, of course, there's also, the question maybe Tony Abbott was referring to, meaning, what about cold? Is cold-related deaths compensating, in a way, by decreasing? Actually, this is not the case in most of the regions. This graph is showing the so-called net effect, that is, the bars in blue and red are the changes in cold and heat-related deaths, respectively. But, the square with the confidence intervals represent the so-called net change, meaning what is the net change in the mortality, excess mortality, due to what we call non-optimal temperature, including both heat and cold. And we see that in many regions, in particular, North America, Central America, Central Europe, South America, and we all measure a net increase in mortality. Confidence intervals very wide for many reasons, both because of the uncertainty in the climate models, but also the uncertainty in the estimation of the exposure-response relationship. But again, there are some regions, in particular south of Europe, but mostly Southeast Asia, that apart from the large confidence intervals, they indicate a dramatic increase and a massive effect of non-optimal temperature due to climate change. Now, this is the graph about the net change, and there are some areas colored in red, which shows this dramatic increase. I want to stress the fact that these areas represent populations and climates which are substantially underrepresented in our analysis, because you can think, if you connect these to a kind of climatic areas, you can see that all the populations in the tropical areas are not here. So the effect on a global scale can even be more dramatic if compared to the graph that I've just shown. So, just to conclude, this is by far the largest epidemiological studies, trying to make health impact projections using epidemiological evidence, directly estimated from different places, and it covers hundreds of locations around the world. The general result is a pattern of increase in temperature-related excess mortality, that is, on average across all the regions. The increase in cold-related deaths do not compensate for the increase in heat-related deaths. Actually, the reverse in many areas, but there are important geographical differences which could be important to being taken into account in order to develop policies at the local scale. However, on a global scale, we can say that the impact is much reduced under milder global warming scenarios, meaning it is the case that we, implement some mitigation strategies, because even for this specific impact, we can have some benefits. Of course, we have some plan, especially to extend these analysis to areas that are not covered, and also to run all of these in less simplistic scenario, because, for example, we haven't taken into account in this analysis either for demographic changes or adaptation in the population. Thank you.
Thank you, Antonio. We move on to the questions. Where are questions? Okay. Stefan?
Yeah, I have a question. How come that out of all places where there's a net benefit of warming, it's Australia? It looks like Sydney and Melbourne get a reduction in cold mortality. I've lived 6 months in Sydney. It's very difficult to imagine what the mechanism is.
Well, this could be a good point to make, especially after mentioning the Prime Minister of that place. Well, the first thing to say is that for Australia we have just 3 cities, and as you can see in this graph, the results are uncertain even in the more extreme scenarios. In the confidence intervals, they include the null, meaning this decrease that we registered is not significant. There are other reasons, and one of them is that in Australia there is also a very big cold impact due to cold, and for this region in particular, it might be that the decrease in cold-related deaths is also very big, as much as the increase in heat-related deaths. And the final reason is that, at least with the data that they have, but maybe the climatologists can help a bit, the increase that we register in Australia in terms of global warming is milder if compared to other regions, especially tropical regions or the very cold regions in the north in the North Hemisphere, for example, Canada. So these are 3 reasons. As we said, probably we need to do a little bit more research for this specific part of the world.
Okay, we take one more question. It was here. Sorry, back there. Okay, that's fine. So yeah.
So there's an extensive literature that's 100 years old written by epidemiologists on heat stress, and all this involves temperature and moisture, and then other factors. I'm curious to why only temperature in this study you've done your analysis when moisture is such an important part of heat stress?
Well, your question is the specific index that we have used in this study, isn't it?
Well, I mean, it's not just the specific index, but it seems to me that you're only talking about temperature here, and you're not discussing the fact that how humans actually behave in heat and what they physiologically do by to reduce heat by sweating and evaporation of sweat, which involves a huge component of moisture. So to just look at temperature seems to be ignoring a huge part of the problem.
Well, this is of course a limitation of the study. We are just looking this, measuring everything on a kind of ecological scale, meaning we look at the temperature, outdoor temperature, measure it by monitors, and the number of deaths in a specific population. There are pros and cons in doing this if compared to other studies, which I think will be too long to explain here. But apart from the limitation, we think it's a valid way to measure the effect of temperature, although you don't understand exactly how what is the physiological pathway linking the outdoor temperature to a specific cause for mortality or mortality in general.
Okay, so looking at the time, we will move all of the other questions to the coffee break, and we move on to the next speaker, who is Matthew Huber. He's professor at Purdue University, and now we will have a presentation more from the climate side. And I think I have to say it's quite funny that I chair a session where someone shares my last name. So yeah, welcome Andy Huber.
So we're going to change gears a little bit. I can try and link to the previous talks just by noting that I am a climate modeler and I study past climates and future climates, but my mother is an epidemiologist. So I was always supposed to become a doctor, and then I realized I didn't really like being with sick people, and I thought that probably meant I would be an awful doctor. So I went into a field of study where everything and everyone was already dead. I figured that was kind of a place to start. So I started working on past climates and the paleontological record and trying to infer things from that. And I realized that there was a lot of things that I was learning from the past that would apply to the future. And then the next thing I knew, I was working on human health, and my mother was happy. So it's always good to make your mother happy. So I want to provide a very brief paleontological context for this, because these sorts of climate changes have happened in the past, and we actually have some idea of what they look like and what the biological impacts of them are. And I also just want to encourage everyone to think much bigger than they are right now, because the climate changes that are potentially in the offing are much larger than half a degree or 1 degree or 1.5 or 2 or 2.5 or 3 or 4 or 5. Pick a number, you're probably not thinking as big as we could possibly go, and I find the big numbers more interesting. So this is 55 million years ago. This is a non-analog kind of situation, but I am nevertheless going to try and make an analogy just to encourage you to think about what happens when climate change is very large. So let me see if that works. Oh, this just moved. I just want this. I'll use my own. God damn it. All right. So this is a record of tropical sea surface temperatures 55 million years ago during the Paleocene-Eocene thermal maximum, which is a period when a huge amount of carbon was released into the atmosphere, causing a massive warming of the world by about 5 or 6 degrees. And during this period of time, the tropics as a whole warmed from a temperature of about 34 degrees C to a temperature of around 36 or 37 degrees C, which, just to point this out, is really hot. This is the ocean, so it's maximally evaporatively cooled, and it's 7 or so, 8 degrees warmer than the region would be today. And the interesting thing that happens when you warm the world by that much Actually, normally we find these temperature records in carbonate, which, little things that build shells on the shelves. Shells on the shelves. Seashells, yeah, anyway. Actually, those are all gone, so they're all dead. So the carbonate producers during this period of time already are kind of cooked and dead. And this is a record of dinoflagellate cysts. Dinoflagellates are the things that cause red tide. They're, generally speaking, pretty nasty. But the interesting thing is they go regionally extinct right during this warming. So this is actually, you find a bunch of them, but that's actually just their dead bodies. And then after that, you don't find any of them for 100,000 years. So it is actually possible for the tropics to get so hot from the geological record that things die en masse. Okay? So just don't think that, like, even on long time scales, millions or hundreds of thousands of years, that life always finds a way. Sometimes it just dies. Whereas in mid-latitude, so this is a record of the earliest horses. Some of you may know that the earliest horses were about that big. So they start off, this is actually a record based on tooth size. And so the earliest horses come in and they're about the size of a dog. And during this very warm spell, where the world warmed up by 5 degrees, they shrink to the size of a cat. So they were about that big, and then the horses shrink to be about that big. And then when the warming stops, they come back again to being dog-sized. So on long time scales, amazing things happen, all right? So don't just think small, accept the fact that the climate changes that we're thinking about as we move into the future are potentially large. I'm going to be talking about temperature and humidity as sort of a driving force in all of this. And I think it's really important to understand that people have been studying this for a long time. Nathan, the other Haldane, has this fascinating paper for 1905. He was famous for doing experiments on himself and his children, his son. Anyway, they did crazy things. This is the person who invented the gas mask. So he was pointing out in 1905 that people had known since 1775 that if you walk into a room and heat it up to 250 degrees, a person can walk out and be fine and a steak will be cooked. Okay? And the reason being that we lose most of our heat, 80% of our heat, by sweating. And steaks don't sweat, although they get nice and crispy and a little bit of blood comes out, and I love it. So he showed in 1905 that we should really be thinking about, for maximal temperature limits, for the kind of ultimate stressor on human being, we should be thinking about something called the wet bulb thermometer temperature. And the wet bulb thermometer temperature is essentially, just imagine you take a thermometer, put a wet sock around it and swing it around your head. That's the temperature of a maximally cooled thermometer, okay? It's not the dry bulb thermometer. It's not the one you're used to thinking about, and it's also not the wet bulb globe thermometer that somebody else was talking about earlier, which includes a radiative component. So wet bulb is really just, there's no radiation, just wet sock, swing it around your head. Now, human beings are not wet socks, but if we drink an infinite amount of water and there's a strong wind blowing on us, then the temperature of our skin will approach that of a wet bulb thermometer. So it's a useful kind of upper limit for temperature tolerance for humans. And he showed, again, back in 1905, that we need to be thinking about limits of something like 31 degrees C for people being able to do labor. This is not really a limit that you can go much beyond, even if you're acclimated. And the reason being that even if you're just sitting here, you're all generating about 100 watts of energy, and you have to lose that heat, otherwise you gradually cook yourself. And the way you do that is primarily by sweating, and the temperature that you can reach if you are sweating maximally is set by the wet bulb temperature of the air around you. So your internal temperature is something like 37 degrees. Your skin had better be cooler than that, otherwise you cook. And so you have this upper limit of 35 or so for just kind of sitting there, and a lower number if you want to do anything. So if you look at today, the maximal wet bulb temperature ever recorded on the planet, if you look, you tend to get high values where it's hot and moist. So kind of in northern India, parts of China, the maritime continent, Brazil. If you were in the Sahara, however, the maximal wet bulb temperature you might expect in any given year would only be, say, about 20 degrees, as opposed to, say, 25, 26, 27, 28, 30 in some of these other regions. So as long as it's dry, you're fine, right? So if you're in the Sahara and you're in the shade and there's a strong wind and you're drinking water, you're fine, okay? If you go to a much warmer world, and I'm talking a much warmer world, this is what ends up happening. Basically everywhere that's this kind of horrible light purple color, somewhere between yellow and purple, I never know what to call it, right? It's this color here. Everywhere that's there or going to the horrible purple color is above the 35-degree wet bulb limit, and when you're above that kind of temperature for more than about 3 hours, you end up dying. So you can think about all of these as death zones, and that covers about half of the world's population today. Now, what does it take to get that kind of massive wet bulb increase? Well, something more like about a 10-degree global mean change. So it's a huge number. We came up with this in this paper because Steve Sherwood kind of asked me the very general question, well, he asked himself and then he asked me, and then we asked each other, is there a limit to what people can stand? We were not trying to do some sort of epidemiological study of what's going to happen 10 years from now. We were just saying, how hot does it get before mammals start having serious problems? Okay, so it was a theoretical study. But it's important to recognize that we probably will not have 10 degrees of warming, absolutely. But this is for individuals who are in the shade, not doing anything, and drinking infinite amounts of water with a wind blowing. The actual limits of real human beings are substantially lower than this, and we've seen a lot of talks talking about bumping into those limits even with current conditions. The nice thing about doing a theoretical study is you can develop a scaling relationship as we did here. This is tropical mean temperature versus sort of the 75th percentile exceedance value for wet bulb temperature. And the key point being just this, that for every degree that the tropics warm, the maximum wet bulb temperature goes up by a degree. All right, so the reason why we did this was just so we could have a simple theoretical understanding. This was one model, and it was an idealized case. John Boujan, who's here, has been doing much more, and maybe you saw his poster. You can go talk to him. We have evidence that this scaling relationship is extremely robust. Now, when I say that 10 degrees C is not going to happen, let's just keep in mind that with RCP 8.5, if you start going beyond 2100, this is RCP 8.5 in the extension period, and this is the range of values. So I'm not saying we're on 8.5 or we will be on 8.5 for 300 years, but what I'm saying is that this is definitely a future which is incredibly hot and we can and should avoid. And I think one of the ways to avoid it is by talking about what it looks like and not just ignoring it. You're talking about temperature changes here that are easily 8 to 10 degrees. Even with RCP 4.5, what a lot of people tend to forget is that those models are still warming in 2100. And if you continue out, they continue warming quite substantially. The only paths that avoid that are something like, I'm being general here, something like RCP 2.6. So, we need to be thinking about and talking about climate changes that are on the order of 4 or 5 degrees or bigger. So a lot of what we've been doing in my group is trying to provide information that's useful for people. There are many different ways of estimating heat stress. Every country has a different standard, a different metric. It's tuned and calibrated to work well for that region. There's different metrics for livestock and energy use. We have a freely available open source code that allows people to calculate a wide variety of metrics in a similar way. And some of the metrics include heat index, which is a rather complex polynomial function of temperature and humidity, simplified wet bulb globe temperature, which involves temperature and humidity as well, but in different combinations. I just throw these up here because they're commonly used, but I also want to indicate that these different metrics, all of which are used by different groups around the world weight temperature, humidity differently. We have theories for how temperature will change in the future, and we have models that agree with those theories quite well, but we don't really have a good general theory for how the covariance, instantaneous covariance, right, at each individual hourly point in time, the temperature and humidity covariance will change in time. And we don't know how these different metrics will filter those covariances. So one of the things that we did was try, through the windows of these different kinds of metrics, try and understand if you have a big extreme in simplified wet bulb globe temperature or a big extreme in heat index, was that due to an extreme value in temperature or humidity? It's actually an interesting question. So we have maps of those regimes over here, and if it's humidity extreme dominated, it's green, and if it's temperature extreme dominated, it's purple, and if it's both equally, it's white. And you see that, so for simplified wet bulb globe temperature, it's a mix of temperature and humidity dominated. For heat index, it's all temperature, and for wet bulb, actually it's a mixture of temperature and humidity, but quite a lot of humidity variations being very important. So I think it's very important to understand the role that the instantaneous covariances of temperature and humidity play in all of this. So there's this influential paper by Dunn et al. Looking at how heat stress will impact labor capacity through this variable of simplified wet bulb globe temperature. And so we've done the same analysis with 18 climate models rather than one in the CMIP5 ensemble, and we find, so now what we've done is provide information in the form of degrees of temperature change rather than time, okay? So for each degree of global mean surface temperature change, we can tell you what, regionally speaking, what the change in labor capacity will be. So the nice thing about this way of doing it is you can kind of take climate models out of it, at least explicitly. We've done all the climate modeling work for you. So if you think if you think that the global climate change will be 1 degree or 2 degrees or 3 degrees or 4 degrees, you can read the labor capacity change off of there. And we've done all the work with the temperature and humidity covariances for you. So am I about done? All right. So I will skip that and just put up my conclusions. Thank you.
Thank you, Matthew. Questions? Rainer?
My question fits also your talk. We have a new kind of heat stress which is observed in Puerto Rico right now, where we have extreme weather events taking out air conditioning. And you said 23 degrees, or somebody before you, is the optimum temperature indoors, and now we have 80% of the Puerto Rican population living the outside temperature. So that is, if you like, a new sort of heat waves. Has anybody thought about this, that most of the electricity in poor countries and in the United States, I must say, is on poles that are very vulnerable to destruction by winds, and that this might be maybe a larger heat stress than the classical heat waves from heating outside?
Yeah, so I mean, I think that's a really important point. I would say that there hasn't been a huge literature on that, or even much of any at all, but that many of us are heading in that direction. My personal feeling is that we will evolve rather quickly to a state where air conditioning is more or less a right. There will probably be international law that says, you know, you're going to die without this, so therefore you have to have it. But it's important to think about what's going to happen when you have billions of people who currently don't have air conditioning get on the grid, the energy grid, to have air conditioning. What are the carbon implications of the world having to be air conditioned? That's huge. And then what if it fails? Then you have millions of people dying in a heat wave all at once.
Okay, thank you. So we will then move to the last speaker of our session, who is Andy Morse from University of Liverpool, and we have heard a lot about heat stress. We will now hear about vector-borne diseases. Welcome. The floor is yours.
Hi, good morning everyone. I'd like to thank the organisers for inviting me. Great to be here and speaking. And my talk came up, even better. So we're moving away perhaps from non-infectious diseases into infectious diseases. I'm going to just talk about one. I'm going to talk about malaria, but I want to talk over different timescales, both over seasonal scales and over climate change timescales. Thank my co-authors who are past grad students and postdocs of mine, and Cyril's in the audience and running a workshop this afternoon. So a little bit of background. How do you get an infectious disease? Well, you need several components. You need the pathogen. For malaria, the pathogen's a parasite. But it might be a virus. For other diseases, it might be bacteria. The environment has to be right, and the climate has to be right for both the vector, so that's a blood-sucking sort of beastie. In this case, for malaria, it's a mosquito. The environment and the climate has to be right for the vector. But it also has to be right for the pathogen to develop inside of the vector. And finally, you have to have a host, something that's going to become that's susceptible to that disease. And of course, you have to have the vector present as well. So we have vectors for malaria in the UK. Europe had malaria up until the 1950s. And the vectors are still there, but the pathogen isn't, unless it gets reintroduced. And malaria in Europe is not going to become a public health problem, but we have seen emergence of other viruses carried by mosquitoes, particularly in southern Europe. So quite a long time ago now, we developed a malaria model based on the model of Joan Aaron and Bob May. And we just put some extra bits into it. But it's really a kind of simple approach that we have these sort of boxes. And the development of the mosquito and the development of the parasite in the mosquito moves along these boxes. So in terms of the mosquito side, I don't know if you can see no, you can't see the mouse, okay. So we start off with susceptible, the S in the adult mosquito. If it bites an infectious human, a human that's developed malaria from a previous mosquito bite, then it becomes exposed, it moves on to that box labeled E, and there's a latency period for the parasite to develop inside the mosquito. And everything has to be right. The mosquito, the female mosquito, is probably going to take 3 blood meals in that time. It takes about 10 days roughly at tropical rainy season temperatures for the parasite to develop. If we were dealing with viruses, they actually develop far quicker on the whole. Then eventually, if that mosquito survives long enough, they don't die of old age normally, it becomes infectious. And that infectious mosquito then, of course, can go and bite a susceptible human, and so it goes on. So how do we tie this to climate? Our model only has climate in it and makes it simple, but it also ignores some of the complexities. And we drive it with daily temperature and a 10-day accumulation of rainfall. And we can take that data from anywhere. It could be a weather station, it could be a climate model, it could be a seasonal model, it could be past gridded data. And I think one of the things that we've done in Liverpool is that we've run the same model across different timescales. As you'll see in a moment, that allows us to verify our model against observations in the current timescales, which gives us a little more confidence when we run it into the future. Right. So seasonal scales, and we're talking about timescales out to 6 to 9 months into the future. So in a tropical situation, we're really looking at predictions of the next rainy season. Of course, these predictions can be used by other sectors, by agriculture, by water resources, and of course in Europe they're also used by insurance and energy providers. So what's a seasonal forecast? Well, when you make a forecast over past a few days, you don't just do one model run, but you do multiple model runs. And here we have an example where there are about 50 model runs. The diagram on the left is the prediction of the last major El Nino, and that's a prediction from August. And the verification line is the dotted blue line, and you can see it's a pretty good forecast. Perhaps it was just slightly over-egging it, but a major El Nino, and you can see that the prediction of El Ninos are pretty good now. On the right is the current forecast, and you can see we're going into a period of cooling. The area here is the center of the Pacific, sea surface temperatures, and we're going into a cooling and going to develop a weak to moderate La Nina. Why is that important? In the tropics, and particularly around the Pacific Ocean and Indian Ocean, then the sea surface temperatures in the Pacific drive a lot of the rainfall patterns. And of course, if it's wet, it's great for mosquitoes. So if you can have some handle on the prediction of the rainfall and the temperature ahead of time, then you can start to develop something like a prototype early warning system. So how good is the model? Well, it's not perfect. No model ever is. And this is quite a complicated diagram, and I think one of the arts we're still trying to develop is how we communicate complex probabilistic forecasts to the user. And this is really still an expert diagram. What it shows you are past runs of the model. Now, this technology is fairly new. It developed around the turn of this century. But if we had it back in the 80s, and this figure goes back to 82, how would have our malaria model worked, driven with a seasonal forecast? This is for Botswana. Why are we working in Botswana? Because it has a long clinical malaria record. Now, getting infectious disease data is very difficult compared with, say, I'm sure the agricultural people say it's also not easy, but you can get yield data a little bit more easily. You can get energy demand data and water use data. Infectious disease data is very difficult to get a hold of. And we developed this form of diagram, and it has the raw output from our malaria model driven by a seasonal forecast. And the numbers up the left-hand side, which are a bit small to see, are the percentage of models that said it was going to be a high malaria year. Now, we just split it into thirds, and this is the upper third. So how many of the model runs said we'd get an upper third event, an upper tercile event? What else is on there? The solid columns are where the event was observed, and the white columns are where it was not observed. So it's observed a third of the time, as you'd expect. The red line is we've put in an arbitrary decision-making threshold, and that is a discussion you need to have with the user, and we've happened to set it here arbitrarily at 50%. So we're saying if 50% of our model runs say hi, we'll make a decision based on that. It's a go. Yeah, we'll roll stuff out. So how did we get on? Well, the field columns, the black columns above the red line, are we call hits. We forecast the event and the event was observed. That's great, everything works. Not so great are the two white columns that are above the red line, because there we said the event was going to occur, but it didn't occur. So that's false alarm. And the black columns below the line are where the event occurred and we didn't forecast it. So we don't get it right all of the time, and it's how you manage that expectation to the user. We get 22 years right. On the 22 years on there, we get it right 17 times. That's about 77%. It's better than guessing, but it's far from perfect, and it will never be perfect. But perhaps we can make it a little bit better. Let's move on to climate change. One of the first things we started to look at was how the variable data sets, the climate data sets, how they varied in the way in which they drove the malaria model. And we have different data sets there from different sources, and I won't go through them for time. But you can see the general patterns are the same. They've got different resolutions and some differences. And we went down this way for some time, but more recently, we've realized actually the greatest uncertainty is in the malaria model, or the collection of malaria models, because our empirical evidence that builds those models is not always great, and there is uncertainty in the impacts model. So let's look forward to the future. So we're looking at East Africa. The last animation, sorry, was Kenya, but you all knew that because you're all good geographers, I'm sure. We're looking at East Africa, and we have RCP 4.5 and 8.5. And again, we're just looking at a kind of the colouring scheme. The opacity of it is a sort of signal-to-noise ratio. And anywhere that's orange and red, we're seeing an increase in the length of the malaria season. The places that really show up, if you can spot Lake Victoria somewhere in the middle of that map, then the Ethiopia, Kenya, and all the upland areas, we see an increase in the length of the malaria season as time goes on. And of course, that pattern is stronger with the higher emission scenario. But the pattern is there almost from the start, and it just strengthens. And it's already changing. So just very quickly, some current interests. We're doing underpinning field research in Tanzania. We went semi-operational a while ago, but the money ran out, and we're going to try again now with NOAA. So we'll try and operationalize. We'll go from the R&D to the operational settings. It worries me if we're going to put stuff out live, but we have to somewhere make that jump. We've worked on climate change with ISIMIP, and ISIMIP data was in that last figure. ISIMIP 2, we're not sure, I'm afraid, but we've been also looking at the NASA data sets. And we've most recently been doing some work with MSF, Médecins Sans Frontières in Congo, because they've had malaria appearing. It's an area where there's a lot of civil unrest or military unrest, and they've started to have malaria appearing in their field hospitals where it's never appeared before. And if you look at the temperature data, these are temperature anomalies based on the 61 to 90 average. But at the start of that figure, the mean annual temperature was around 19.3 degrees. By the end, it's 20.2 degrees. And you can see the warming. And that's around 18 is the absolute critical threshold for the type of malaria that they get in Africa. And you have to get into the low 20s before it really efficiently transmits. And there's again a strong climate driver, but there's also social and other drivers. So just to conclude very quickly, why are there few people working on these types of data sets? Well, they're big and difficult to use. And some of the work that's been done here on ISIMIP has really opened up data sets to the wider users. Why does health and climate not work so well as climate and water and climate and food? I don't know. It's a much more recent nexus, and it really needs some support to roll it out of its still infancy. There's a lot of demand for information in Africa. We've shown, I think, here that seasonal forecasts do have skill. We know now, I think, that the climate will impact on malaria, shift it up the mountains in East Africa. And as I said, the methods and that we use are applicable to other areas. But you have to communicate. And communicating often means going out to the centre of Senegal with local practitioners talking to the villagers. Thanks for your attention, and thanks to all our funders.
Okay, so we take 2 questions. Yeah.
Thank you for the opportunity to ask a question. I come from Kenya, so I got an interest in 2 sections of your talk. First of all, you talked about early warning systems. So that is one of the areas I didn't get very well. Who are you warning? Is it the government? Is it the health practitioners? Or is it the community that is exposed?
Okay, I think I call that who we're working with, and we're mostly working with other scientists, and we're trying to work with in Kenya we have had contact in past projects with the Ministry of Health, but it's mostly universities and also the Malaria Research Institute, KIMRI.
You also mentioned that malaria is going up the mountains now. Just in the last 2 weeks, we had malaria outbreak in the arid regions, and all of us know arid regions are much lower. It's a new case, yes, but I don't know if I'm the one who have not read, but this is a dry land areas, and now we have an outbreak of malaria.
So, so you've had rain after drought, yeah? No rain?
No rain yet.
Right, I don't know then. I mean, if there's no rain, then the mosquitoes are breeding in some either irrigated area to get enough mosquitoes and enough spread. But often you get infectious disease outbreaks, vector-borne, after drought, following the initial rains that are worse than usual. We don't really understand that. But if it's had no rain, I don't know why you've got malaria outbreak.
Okay. There was one other question here. Yeah.
Thanks. Hi, Kira Fink from the Potsdam Institute. I was wondering if you know whether there's any interaction between infectious disease and human migration.
Well, certainly migrants can introduce pathogens to susceptible areas. So many outbreaks of many infectious diseases are around refugee camps, people that are moving. Is that what you're asking, or you're asking it the other way around?
This is very interesting, but I would also like to know whether there is if it's a driver of migration, infectious disease.
Okay, that's what you're asking. I don't know. We're looking at some work in ancient Greece, ancient Turkey, sorry. And there are some suggestions that the movement up and down the valley side was perhaps driven by malaria. And we've done a trial project, and we're trying to get funding to look at that now with the archaeologists. Currently, I don't know. If you go to villages in Africa, they build their villages away, kind of as far away as they can from the water source to the breeding site. And if you look at the sort of theoretical travel of mosquitoes and the distances, they're about spot on. So the local knowledge of avoiding the worst of the mosquitoes is certainly there. I don't know if it drives migration, not vector-borne disease.
Okay, so then we thank again all speakers of the session, and if I'm not mistaken, we reconvene here at 11. Okay, thank you.